All right. Good morning, guys. How are you?
Morning.
Good morning. All right. So obviously, how do you compete with Dr. Veej? You know, that was a great lecture. I'm gonna try. Mine won't be as sexy, but mine definitely will be informative. Here we go. Got a little stragglers. So I'm Dr. Reddy. I'm a local oral surgeon in St. Louis. I joined the group of Southwest Oral Surgery. You may be shocked to know I'm the youngest of the group. This is Dr. Kramer, Oglander, and Tosh. You think I'm kind of the big guy in the middle, but no, I am the lowest of the low in this group. So just to let you know, I joined the group around 3 years ago, and I've had the privilege to work with ATSU. I teach, I guess, on the floor clinically, as well as I teach the undergrad, or I guess the oral surgery course up in Kirksville. So I've had the the privilege of being part of this great school, and this is our first updates in clinical, I guess, dentistry, and we're hoping to do many more in the future. And we appreciate you guys coming up to, obviously support us. So what is my topic today? Well, mine is anticoagulation, and I already kind of gave the punchline over here. I'm hoping that most of what I'm talking about is not going to blow your mind, but I'm sure it will. What really got me into this lecture was the fact that a lot of the literature is actually fairly recent, looking at 2015, 2016, even articles in 2017. What kind of brought me down this path was, obviously, there's a lot of new anticoagulants on the market. They're being advertised directly to your patients now. So there's a lot of things that we have to learn. So, obviously patients look at us, we are the doctors, we're expected to know all this. And obviously our patients are kind enough to put their faith in us. So today I'm going to hopefully demystify some of the, scare of bleeding, essentially, or anticoagulations. So the first thing is, everyone has a bad day. Don't think you're the only one, on your island. We all have bad things happen to us, So, obviously, when we start, obviously, as an oral surgeon, I kind of get, lucky most of the time. And I obviously push the limit a little bit, if it didn't happen before, it won't happen again. But here's a little kind of, video that'll kind of show you that even, I have bad days as well. See if it'll play for you over here. So the funny thing about this video is that obviously I was cocky, I'm oral surgeon. And I was taping a video for the students on infection. I'm like, this is a great case. It's in my office. I do it 1,000 times, at least 4 times a month. I'm opening these up for big, nasty infection. So of course I'm taping it. All the staff is around, and this happens. Sorry. Yeah, you don't know. I'm trying to talk through, trying to explain things to the students. Remember, I do this at least 4 times a month. Usually it's a hospital setting, but I got cocky, because it was a Friday at 3 o'clock, usual thing. They come to my office, patients in pain, and I did it right there and then. And of course, this happens. The one time, never in the OR, only in my office. That being said, the good news is bleeding always stops. The bad news is bleeding always stops. Let's kind of go over, why we're, in the good news, kind of realm. Is that this is known as a classes of hemorrhagic shocks. Essentially, when we're actually going to see changes in our patients after they start losing blood. Fortunately, you can lose up to 1.5 liters of blood before your patients actually start having effects from this. So you can see we kind of hang out in the class 1, where basically there's no change in the blood pressure, the pulse is normal, and really there's nothing changing in our patients' physiology. Once you get to class 2 hemorrhage, once again, our bodies are amazing. They adapt to a lot of things. I've learned one thing, going through residency, that it takes a lot to hurt and kill a patient. Trust me on this. I've done a lot of crazy things, not always smart things, but that being said, it's only when you get the class 2 shock, you start seeing, the pulse pressure decrease. Again, the blood pressure is still normal. Pulse rate starts to increase a little, 100 to 120. Nothing that really kind of scares me. And once you go past 1.5 liters of blood, and this is liters of blood, then you actually start seeing the effects where your blood pressure starts to drop, your pulse rate really starts to increase greatly, and patients now are becoming more anxious and confused. Okay, so there's you have a lot of time to worry about these bleeds. So it's not, so obviously the first thing of any medical emergency is to calm down, relax, and just think about you have time. Okay, and said to lose 1.5 liters of blood, you need something like what I did, an artery pump, and having the ooze in the mouth, very unlikely to actually ever reach those levels. So I hope you're all taking notes. I'm sure you've all been over this like 30 times already during your careers. This is the coagulation cycle. So there's 2 ways which our body kind of clots. We have the intrinsic system, which basically is vessel damage, okay, and the extrinsic system, which basically is when what actually is exposure to damaged tissue and collagen and all those things. So the main thing is that they all kind of cycle down to the common pathway, and then factor 10, and then we have the prothrombin to thrombin, and thrombin then converts fibrinogen to fibrin. And then we kind of get this mesh of fibrin that kind of helps form the initial clot, and it attracts platelets which bind to it, actually activates the platelets and causes even more clotting to happen. Okay, so there's kind of a positive feedback cycle there. Now, some nerd somewhere in some chemistry lab figured all this out and has figured out ways to basically block the pathway along somewhere here. Okay, also over here. So there's some really, really smart people who have found a way to prevent this from happening, which is good and bad. Good because it's saving lots of lives. Bad, when we're doing surgery, it can cause to have a few headaches. So let's get right into it. Aspirin. Who's on aspirin here? Okay, so the thing is with aspirin, it's been around for a very, very long time, about 400 BC. Hippocrates, prescribed it for headaches and pain and fevers. It's been around for so long that now it's available over the counter. And the problem with that is that once you put something over the counter, patients forget it's even a drug anymore. They think it's very, very safe, and they may not even mention it to you. Okay, it was actually Dr. Felix Hoffmann who actually first synthesized aspirin in a lab. All right, and he actually worked for the Bayer company. Funny thing is also Felix Hoffmann that actually created a drug called diamorphine, also known as heroin. And they actually were prescribing that for headaches and pain back then. And it's funny that you never hear much history, from 1900 to 1910. I don't know what's going on back then, but Hoffman actually was the first to kind of get aspirin going. Okay, it was actually John Robert back in the 1960s that actually found out the actual pathway of how aspirin works. He won the Nobel Prize in 1971. So what does aspirin actually do? And I'm sure we all know this as well. This is not something that's new. But aspirin, actually blocks the enzyme cyclooxygenase 1, which prevents, thromboxane from forming, which basically leads to the prevention of platelet activation and aggregation. Okay, so aspirin is probably the most commonly, most common NSAID, that people use. And we basically found over the years that aspirin actually acts as a great cardioprotective drug as it blocks COX-1. Now, as I said, COX-1 is involved with conversion of thromboxane A2, which is how we get our effects. And it's given to all patients after a heart attack or those with risk factors. Now, think about that for a second. Those with risk factors. How do obviously increase in age is a risk factor. Lifestyle, diabetes, hyperlipidemia, vascular disease. These all sound, familiar to you. How many of your patients have these, right? So it is just prominent. It is estimated that 41% of Americans over the age of 40 is on aspirin. That's a huge amount of your patients. Okay, but said it's a great drug, as we know.
the antiplatelet effects decreases vascular disease complications, by 15% and non-fatal ones by 30%. That little pill you get for, $5 for 1,000 of them over the counter at Walgreens, it's a wonderful medication, okay? Now, here's some others, obviously diabetes, patients who have diabetes, is like how much of your patient pool is a diabetic type 2? These patients have a lot of macrovascular or microvascular disease, so those big arteries and their small arteries. 65% will have death due to, vascular disease. So it's going to be in your diabetic patients as well, all right? Also those who have atrial fibrillation, most common tachyarrhythmia, but 5% of these patients will actually perish every year if they're not treated, okay? And these are just some examples of what aspirin can be used for. Obviously, we got to take the good with the bad, all right? So these are two, common ways which platelets can cause a muck. The first one is, the one that we always see in the textbook, that being atherosclerotic plaques. And you see when you have buildup of fats and bony cells and white blood cells, which leads to damage of the vessel, it causes the platelet aggregation, can lead to narrowing of the lumen of the vessel, as well as plaques can actually break off and go into the brain and cause ischemia there. Or patients with high blood pressure, or even the AFib, or any kind of arrhythmia can cause damage to the actual vessel itself, and that can lead to the aggregation, leads to stroke and acute coronary syndrome. So platelets are, they're troublemakers when they aren't kind of kept under control. Now, here's a question. 81 milligrams versus 325. Ever wonder why your patients are on one or the other, high dose versus low dose? As we know, if we see a patient's med list, we can basically find out what they're being treated for and what they're suffering from. So who gets 81 milligrams? Well, patients who basically have a history of an MI or thrombus or who've had stroke. Those patients benefit from the low dose, or 81 milligrams. These studies do show, they're usually around. So the studies that you see will always look at 75 to 100 milligrams, but 81 milligrams has kind of been found to be the best kind of range there, all right? Those are on high dose aspirin, or 325. Those are the patients who have AFib, all right? So now you know which one is for which, okay? So let's kind of talk about aspirin and how, once again, it's just so common that we really don't even think of it anymore, but, the thing about aspirin is that it is a drug. It does have, an effect on our ability to, clot. And we always think about aspirin and oral surgery. Every study out there, I'll admit the overwhelming majority is on dental extractions. And we really think, how does it affect our daily practice, okay? I love this article. It came out of the Journal of Periodontology in 2002, all right? And what they did, they had three groups. They had healthy individuals with, who are apparently healthy, and they basically did, a probing depth on them. And then they put them in either one of three groups. One, which had aspirin at 81 milligrams for 7 days. The other group had 325 milligrams daily for 7 days. And another one just had a placebo. And what they found is that patients who were taking 325 milligrams of aspirin, who had probing depths, about 20% or more, had an increase in the amount of bleeding on probing depths on day 7. Okay, those who had 81 milligrams had no difference, and the placebo had no difference. But think about this for 1 second. We always think about bleeding and oral surgery. Now, if your patient, if you're just doing a daily routine cleaning on them, how many patients have you shifted over from gingivitis to periodontitis and went from, prophy to scaling root planing? So and the thing is, we are constantly working with sharp instruments in the mouth. We're giving blocks, we're using traction cord, we're accidentally cutting the tongue. It happens. But these all things can affect just your daily, treatment on these patients, not only invasive treatment. So these can actually change your diagnosis. So I thought this was a really good paper, because rarely do we ever see something that we do and take so, I guess, lackadaisically in our practice daily. Now, this study looked at low dose aspirin, okay, in 51 patients. And this actually showed that patients who were on low dose aspirin, between 75 to 100 milligrams of aspirin daily, actually had no increase in bleeding, I guess, complications after dental extraction. There was a little bit more oozing, but nothing that couldn't just be stopped with just normal pressure. This one came out in 2006 looking at high dose aspirin, okay? And they basically found, again, that there was no difference in the bleeding in those for high dose aspirin users. So I kind of brought you both articles kind of to see that really aspirin is a great drug, but we really shouldn't stop it yet. So why shouldn't we stop aspirin? Okay, because at least when I was in dental school back in 2009, I'm that old, they actually always said to stop it 5 days before. Why 5 days? Because we know that in 5 days, 50% of the platelets will regenerate and you'll basically clot like anyone else. But there's now evidence that shows that there's something called platelet rebound phenomenon, okay? What that is that basically when you stop or when you stop the aspirin, thromboxane and prostaglandins kind of build up and put you in a pro-thrombotic state. You actually want to clot more so now than obviously when you're on aspirin. And they're basically finding that patients who stop the aspirin get heart attacks about 10 days later. Okay, so you have an increase in actually having a heart attack 10 days after stopping your aspirin, okay? Which actually is consistent with the time interval of this platelet rebounding effect. So that's kind of scary. You know, the patient comes in and get one tooth out, and all of a sudden you're increasing the chance of them having a heart attack. Now, why is all that come about? It was this article it's actually done in the European Heart Journal back in 2006. So it's been around for a while. And they looked at 50,279 patients. All right, that's a pretty good number, pretty high power there. And they basically identified that patients who stopped aspirin were at 3 times a higher risk of having a cardiac event at day 10, and those who actually had a stent placed actually had a higher risk at day 7. So you actually have a 3 times more risk of having a heart attack after stopping aspirin, right? So all those, so the drug that you use to help to prevent heart attack, if you stop it, well, apparently it's pretty effective at, protecting you. Now, a little extra, info about aspirin, because a lot of the times we prescribe our patients ibuprofen after, routine dental care. Now, we know that aspirin and ibuprofen work on the same receptor. Aspirin is non-reversible, ibuprofen is. But the question is, patients who are on aspirin, how do you dose them correctly to make sure they still get that cardioprotective effect? Well, the idea here is that aspirin basically is absorbed in 30 minutes, okay? And obviously enteric-coated is about 2 to 3 hours. So what you want to do just to give your patients the ability or the cardioprotective effect is to dose the ibuprofen 30 minutes after their aspirin, or wait till after the last dose, 8 hours after the last dose of ibuprofen. That's kind of something that we don't usually think about, but do play a role in our patient's care, okay? Now, this is the newer class of anticoagulants, the adenosine diphosphate receptor inhibitors. So the first drug from this class was Ticlid. Back in 1978, it was a great drug. It was for those patients who could not handle aspirin. The problem with Ticlid, it actually causes TPP or thrombocytopenic purpura. Basically, it's an immune system thing against our blood vessels. So clopidogrel, I'm sure you all saw the ads for, was introduced in 1997, and basically they found that clopidogrel had less rates of TPP, and therefore basically TPP dropped out of favor. And in fact, in 2015, no longer could you get Ticlid on the U.S. market. Now, the newest drug coming out is Brilinta. I don't know if you guys have seen it in your patients. Also part of the ADP class of anticoagulants. This now actually is coming on strong because it's actually been found to be more effective than Plavix. But all in all, the ADP in inhibitors all kind of work the same way and are managed the same way. So there's more studies on Plavix than all the other ones. So therefore, I'll kind of use Plavix as the example on how to manage these patients. Okay, and I'm sure you've seen Plavix many, many times. So clopidogrel, Plavix, it irreversibly binds to ADP. It's usually found in 75 milligrams. And it's commonly used as dual platelet therapy alongside aspirin to reduce the risk of coronary stent occlusion. And I'll go over that in a minute, but this is the big, I don't know, Slimer from Ghostbusters or a platelet. Essentially, as you see, ADP or clopidogrel, or even thromboxane from aspirin blocking, all kind of works to work on this glycoprotein 2B2A receptor. That prevents it from binding to fibrinogen, also activating plates and actually having them bind to each other as well as to a fibrin clot. This is kind of the cool animation I found online, and I want to throw it in. But yeah, this is how it all kind of works. Now, what is dual antiplatelet therapy? A lot of your patients are going to be on, especially if they had a heart attack, okay? Essentially, it is the combination of aspirin and an ADP blocker. It is mandatory after acute coronary syndrome or stent placement, okay? Now, the thing is, stents behave like unstable plaques, and therefore it can cause these kind of aggregates of this kind of form up, so it actually can be dangerous, all right? Now I'm sure you've all had patients who have had stents placed. What is a stent? A stent is very simple, kind of like, I actually like this name, like Glassbergen, that little cartoon. The idea of a stent is that they put it usually through your arteries in your leg, the femoral artery. They go to your heart, which is unbelievable that they can do this thing. And they kind of have a balloon and a balloon with a stent on it. The balloon and the stent is in place into the actual narrowed lumen. It's blown up the balloon, and they leave a stent behind to keep that artery open. Now, there's two kinds of stents, okay? Obviously, there's many brands, but really there's two kinds of stents, or two classes. One is the bare metal stent, okay? And essentially, it's just a mesh network that kind of helps open the artery. And then there's drug-eluting stents, which has a medication to prevent epithelialization. Now, whether you use one or the other, well, the advantage of having this drug coated on the actual stent is that it'll prevent the buildup of plaques or restenosis of the artery. Now, when would they use the bare metal stent? Is for a patient who is planning on having surgery within the first year. And I'll explain why that is important. Is because you look at this, this is the duration of antiplatelet therapy after coronary syndromes or coronary issues. Now, you have a simple angioplasty without stenting. Basically, they put a balloon there, they put nothing behind. You're on aspirin lifelong. Once again, aspirin's a great drug, and these patients are never cured of their disease. They're just stabilized. Now, PCI or percutaneous intervention, essentially, if you have a bare metal stent, you're going to be on dual platelet for 4 weeks, then aspirin lifelong. And if you have an MI where they have a drug-eluting stent, you're basically going to be on aspirin lifelong and also dual antiplatelet therapy for a year. Now, what we found out in the past 2 years is that patients who were withheld of their dual therapy with the drug-eluting stent within the first year are much more likely to have a restenosis, okay, another heart attack. So your doctors, your cardiologists will not stop dual platelet within the first year. They're much more likely to have another cardiac event. So this is kind of important here to understand, between which stent they have. So when you call, the cardiologist, say, hey, can I stop the therapy on these patients? They're going to say, no, absolutely not. So unfortunately, they're, patients who are alive only can care about, I guess their dental issues. So this is kind of a little idea of, of how we use these drugs and for how long. So here's a common question I always get, because I remember actually Dr. Ganda worked at Tufts, it still is there. He actually taught me about, medical management where I trained. And this book has basically, at least, has become, a cornerstone of our dental education. And for years and years, we've heard that you really can't treat a patient with an MI for the first 6 months, okay?
That's not true anymore. And I can tell you that I've done it all on a patient a month out of stent placement, because really at that time, think about it, their arteries are flowing nice and clean. You have all that blood flow, therefore they can react better to discomfort. So they're actually at the peak fitness. But now that I say that, here's the caveat, all right? Patients with an MI that occurred after, 4 to 6 weeks prior has to meet some criteria. They need to basically have 4 MET units, and their blood pressure has to be managed, less than 180 systolic and less than 110 diastolic. So obviously these are some very easy questions that you can ask them. Can you walk up a flight of stairs carrying groceries? Can you run a short distance? Are you involved in any activities like doubles tennis, playing 9 holes of golf, or dance for at least 5 minutes? So if they kind of answer yes to any of these, you're set. So that's kind of another thing. Now that we're talking about heart attacks, is kind of the new thinking. So this is a little update for you guys. Now, let's look at some studies, okay? This paper came out in 2013. Right, this is after I graduated from medical school and right when I left oral surgery training at Tufts. This was a literature review that looked at 15 studies, okay? And they looked at a bunch of dental treatments, skin root planing, gingivectomies, third molar extractions. And basically, they have found that patients who are on antiplatelet therapy have more initial bleeding in the first 30 minutes, but less than 20%, of the cases in the first 24 hours had any kind of residual bleeding, and at 40 hours there was none. So remember, you have 1.5 liters of blood to lose before you see any kind of systemic reaction. So once again, unless there's artery pumping, you have time. So even though you see 24 hours, don't worry about that. First of all, those gauze are full of saliva. They're saturated with saliva and blood. So you have a lot of time to kind of bandage them until you start thinking, oh my God, I have to the ER or to have to send them to the oral surgeon. Now, this table came out of the oral surgery clinics of North America. Again, all new data, 2016. 2016, guys, this is all new stuff for us. And they basically put recommendations of when to change antiplatelet therapy or dual antiplatelet therapy. And the one caveat about this is that I try to find anything to back all these up. This is simply clinical experience and their own opinion. There's no actual papers mentioned on this. And you'll see a lot of these tables out there, and a lot of hospitals and a lot of clinics will have their own criteria. This is kind of a good guideline. So really, on dual platelet therapy, a single tooth or some soft tissue biopsy less than a centimeter really doesn't stop anything. Then when it comes to medium risk, less than 5 teeth, so here's the thing: placement of 1 to 3 dental implants. In my mind, if you're putting a dental implant in there, really you're putting a mechanical block on the bleeding vessel anyways. So I don't understand where they got these numbers from, but it's kind of their recommendations. So essentially anything from medium, and so for medium risk, they say, hey, you know what? Probably should stop one of them. Okay, obviously after talking to the cardiologist that prescribed it. The rule of thumb, guys, a little note: don't ever stop anything without talking to the cardiologist who prescribed it. Just stay out of trouble. And then once the bleeding stops, you can just restart it, okay? But and once again, for any antiplatelet therapy, it's 5 days, right? So really, it'll be 5 days until you kind of get the effect back again anyways. And so for high risk, once again, greater than 3 implants, tori, greater soft tissue, about is greater than 3 centimeters, which is pretty big. Again, withhold only one of the drugs and restart it after hemostasis is achieved. I can tell you that out of the drug stop, I stop aspirin. Why do I stop aspirin? Because clopidogrel has been studied to help reduce the risk of heart attacks more so than aspirin. So if they actually had an acute coronary syndrome, the aspirin is great, but the Plavix or the clopidogrel has been shown to be more effective. So I usually stop just the aspirin.
Yes. One question. I guess it's a little different between oral surgery and periodontics when it comes to the aspirin issue. In oral surgery, you have the socket, you can put gel foam in there, you can suture over it. In periodontics, especially when you're doing wood planing on patients with advanced periodontal disease, you have a problem with bleeding there. So if they are taking aspirin, you have a bleeder in your hand. And I had a patient one time, she's in her 30s, and she did not tell the patient, the hygienist, that she was taking aspirin. She has no systemic condition. She just took it for pain. She took 2 aspirin before she came. She had
For one dose or for multiple doses?
She took 2.
That, just morning before, but normally she's not on any aspirin.
Before she saw the hygienist, then the hygienist did 2 quadrants on her. She called me at 8 o'clock at night. She said, I'm bleeding. I asked her to apply pressure, just like, the normal thing. And I told her to call me if the bleeding doesn't stop. So she called me at 10 o'clock. She said, it's not stopping. And I said, if it doesn't work, then you have to go to the emergency room. So I sent her to St. John's. She called me at 12 o'clock at night. She said, my mouth is full of blood clots and you need to do something about it. I said, well, go to St. John's. They have a clinic, dental clinic there. They'll take care of you. She went, called me this morning, and the next morning, she said she went to St. John's, but they didn't do much. They just told her about it. She came to my office with her mouth full of blood clots. I cleaned everything out. I had to switch her both quadrant for her to stop the bleeding.
So, thank you for
And
bringing
she
up.
took aspirin also after she went home, not just before she saw the hygienist. She went home and she kept taking the aspirin. And then I told her to stop the aspirin right away, don't take any more aspirin. It's too late.
Well, so there's a few comments on that. One is that, a lot of these studies show that just local hemostatic measures could have prevented that. So as you said, you sutured it up and all of a sudden, you put some pressure in, it got better. So the hygienist may have approached you if she started, fracturing off the patella. She should have told you about that. And we're all gonna have bad days. I'm telling you right now, there's always that black swan out there who's gonna be that weird patient who has just, a bad complication. And it's gonna happen to all of us. I can tell you that I've diagnosed young, patients with even, clotting diseases in the ER, and they never caught on to it till they're, later on in life. And I actually have papers that I wrote on those. And you're right. So some patients, no one's perfect. We all have different issues, and my concern is that if that one dose of aspirin, okay, or 2 tabs of aspirin, just an hour or 2 before, because we know it takes at least half hour to be absorbed, okay. And really, she should have a lot of other plates that are still functional.
She took afterwards also.
Yeah. So 2 doses of aspirin. There's something probably else going on in there. Like a lot of elderly patients will have the bruising in their arms and all of that. Those are all signs where they could have a natural coagulopathy, which is, it may or may not be treated. Well, yeah, no, I understand that. So I think you kind of had an outlier. And just to kind of comment on one more thing about, the emergency room. I did my fellowship at Mercy. There is no dental clinic at Mercy. There is an oral surgeon on call, but the ER won't call us unless it's a really life-threatening bleed. So once again, there's 2 points to this. One is that bleeding, said a lot. Even though it was like 24 hours of bleed, not life-threatening. And 2, most of it can be done in our office with local hemostatic, maneuvers. So I don't want you guys to be scared. I think he had a kind of a bad day patient, and we all have had those. So yeah, but to aspirin said, we take it for granted because it's over the counter, just like your patient did. But that it is a drug. There is complications with it. We take the good with the bad whenever we have any medication in us.
Dr. Ed?
Yes.
Yeah, on that kind of feedback, Dr. Islam, is there a difference in your opinion from like a general dentist office in particular to an oral surgery clinic or office? Okay, for their likely to have hemostatic measures, what are different options for that?
So,
And
yeah.
in those studies in your office, are you considering, or do they consider like laying a flap, like a surgical bone grafting extraction, all that kind of stuff versus a simple?
Yeah, so you're right. So how do we define what is a simple extraction? And the problem is it depends on which article you look at and what guideline. Like, these are all clinical judgment. There's no standardized definition. Thank you for actually bringing that up. So I've read some papers, obviously one extraction with a flap is fine, it's low risk, but you have a multiple which are next to each other, then that's high risk. So it all depends on this is from oral surgery clinics. So obviously our definition of what's hard, what's not, may be different. Now, when it comes to the offices, of a GP, well, the reality is that, there's no excuse for not being ready for an expected complication. If you're pulling teeth, you should have something in your office to help with the coagulation, because you're held to the same standard as everyone else. Obviously, if I was to do endodontics, you don't want me to do that for you, trust me, then I would be held to the same standard, and that's just the reality. So I can tell you that I've had GPs call me before middle of the night. I've been more than happy to come help them, because I know the frustration of going to say, go to the ER, and it's like, well, no one saw me. So I can tell you right now, I'll be giving you my number at the end. It's better to give me a call and come to my office. Not only do I have everything I need there, but it saves a lot of expense and heartache for patients, because they're going to be waiting hours bleeding in there, because it's not considered, a high acute event. And I can probably finish off in my office in about 4 or 5 minutes. And then, in fact, you have my number. If there's any problems, give me a call. I'd be happy to meet you, because I can tell you that I cover St. Clair's, St. Anthony's, St. John's, or Mercy, and also St. Luke's, and said they never call me about a bleed. They say, I don't know if it's kind of being an issue, and that there's no oral surgeon who's gonna come on in, just simply to control a bleed, unless it's really, really bad and they call you in. Let's keep on going forward. All right. So remember, blocking either Aspen or clopidogrel, it takes about 5 days for the platelets to turn back to their baseline. It does lead to what's called a rebound effect, causing your patient to be in a prothrombotic state, and it increases the risk 5 to 10 times of having an MI. And alone, these drugs should not cause significant bleeding where you can't control it in your office. That's what we consider a bleed, which is significant if we can't control it in our office. Atrial fibrillation, about 2.7 million Americans have this. It's the most common serious arrhythmia. I'm sure we all have patients who have this issue, okay? What is atrial fibrillation? Is when the atria beat funny. They just kind of quiver. They actually don't push the blood around. And what happens is the blood kind of becomes stagnant. The platelets adhere to one another, and it creates these clots, and these clots can be shot up through the ventricles and through the aorta and go right to the brain and cause stroke. So, as I said, this is the most common dysrhythmia and we all have to deal with it. And there's 3 ways which we control chronic AFib, okay? And the first way is simply what's called rate control, all right? So these patients are just basically getting beta blockers to help reduce their heart rate. It's a tachyarrhythmia, all right? So therefore, they're bleeding too fast. And we want to basically try and recapture the rate. There's rhythm control, which is not as commonly practiced, only in the acute setting in the hospital. The problem is all these drugs, amiodarone, propanamide, and sotalol, they have a lot of side effects, so you really don't want your patients to be on it for too long. The most common way is controlled is anticoagulation, hence the topic of today. And this is the mainstay. Warfarin is kind of been the most studied. It is the most commonly used, although the new direct anticoagulants are making their way onto the scene, and we'll go over that shortly. But let's talk a little bit about warfarin. First discovered in 1939 from spoiled sweet clover having anticoagulant property. I actually looked up, the uses of sweet clover. How do people figure these things out?
So sweet clover is actually used for fertilizer and stock feed. How do they figure it out? I don't know. There's some really smart people out there. 1948, it was first used to kill, rodents. All right, and then only 6 years later, it is approved for use in humans. Great. And the sad part is actually you can buy this over the counter to kill mice. It's anyways, I'm amazed. So now this this drug is used to treat a ton of medical issues: AFib, deep vein thrombosis, pulmonary embolism, arterial thromboembolism, and mechanical hearts. And also used for stroke prophylaxis. So there are a lot of uses for warfarin. It's been around for so long. We know this drug very, very well. Now, I'm sure usual, dental 101, it inhibits factors 2, 7, 9, 10, protein C and S. It prolongs the PT time, okay? And, as I said, this is, as you see, warfarin has a lot of effects on a lot of systems over here, okay? And obviously, we measure, as you know, warfarin using the International Normalized Ratio. What that is essentially, I think I have over here. Yeah, over here. Essentially, the INR measures, how anticoagulated we are. Normally, you should be between 0.9 and 1.1. The reason why they created INR is because just checking PT time, depending on what lab you use and where you are in the country, there's different different thromboplastin that they added, to the mixture. So so from one lab to the other, to standardize it, they basically created the ISI value, or the International Sensitivity Index value, where they have a index which they can compare other thromboplastins to, and therefore, if you go to a lab in Scandinavia or a lab in St. Louis, you're going to kind of have the same range, all right? So therefore, we know just how well anticoagulated they are. Now, this is what I want to get to, because INR, depending on what medical problem they have a different goal, all right? And I want you to pay close attention to this, that really anything from 2 to 4 is within goal, and that's key. Keep that in mind. So for DVTs or PEs, you're going to be anticoagulated for about 6 months, and your goal is 2 to 3, okay? For a mechanical heart valve, right, which is high risk for getting blood clots formed, their INRs would be 2.5 to 3.5. For a biprosthetic valve, 2 to 3. AFib, the one that we always kind of treat, they're only at 2 to 3. Now, a coronary artery thrombosis or prophylaxis after an acute MI, they can either have an INR 2 to 3 plus aspirin, or or having a goal between 3 to 4 on just warfarin alone. And I can tell you that a lot of people do not have, or a lot of doctors do not, do the high intensity, anticoagulation, because a lot of these patients are older, they're high risk for falls. They can fall and have an intracranial bleed. So usually it's going to be INR between 2 to 3 and aspirin, okay? Once again, the INR is normally from 2 to 4. Keep that in mind. This is a paper. I want you to look, 2015 from Journal of Canadian Dentistry, okay? This study was a literature review, and they basically found that patients with an INR within therapeutic range, so remember that 2 to 4 range, okay, therapeutic range, that they don't have an increase in risk of bleeding that could not be controlled by local agents, things that you do in your office every day, all right? But we do know that the life-saving drug can save many, many people every year. This is one article. This came out again, look at this, 2015. This is just 2 years ago, all right? And again, this was a study by Dr. Walls, which showed that the risk of having a bleed, which you could not stop in your office, versus a complication of an embolic event was 0.6 compared to 0.8. Looking at this over here, this is what I want to point out. So let's again, the INR was always between, usually, 1.7 to 4.0, okay? And here, 1.8 to 4.0. Postoperative bleeds. Patients who were called saying, wait a minute, doc, I'm bleeding. Bleeding complications requiring more than just local measure. Look at this, all goose eggs, zeros. All right, and this is all people who are in therapeutic range. So they're being treated for their, disease, and they can be treated in the dental office for extractions, and say local measure is more than enough to stop the bleed. Yeah, they might ooze longer, but you have 1.5 liters, guys. You have plenty of time. So again, nothing more than local measures. And this is very different than I was trained. When I was in training, I was told warfarin stop for 3 days, get an INR. And so that's only 6 years, well, 8 years ago. And
What
this
do
is
they
all
mean by local measures?
packing, suturing, and we'll go over that, but nothing that you should have in your office. Everything's in your office. So no transfusions, no need for any, coagulation factors, things that's readily available to the dental practitioner. And we'll go over a bunch of things in the end. This is how to how to manage them and how to treat them. Again, obviously with only an hour time, I don't have time to go over everything. So I'm kind of just rushing through the articles. If you email me, I'd be happy to send you all these articles to kind of read over. But the key is that once again, we know that if they can be treated by us and also their disease at the same time, and don't even kind of play with any values. This is kind of the new thinking of dental treatment. Okay. Check the INR within 72 hours if they have a stable INR. Now, what does that mean? Because people who have the same INR again, usually, will carry that trend. People who have kind of INR that kind of varies, usually you want it within 24 hours. I can tell you right now that patients who are on Coumadin have a standing order. That means they can go into their lab and ask for their INR to be drawn, and it'll be done for you, and within a few hours, you're going to have their INR fax to you, or you can call their nurse. Okay, so it's that easy. It's not a big spiel going to their primary care, getting the order. No. If you're on Coumadin, you have a standing order for that. Okay. Now, obviously, warfarin, has a lot of interactions. Not only are they vitamin K dependent, depending on gut flora, but also they're very, bound to albumin, so they have a high reservoir. Okay, so some things that we might do in our everyday practice that actually increase the INR value. The first thing is amoxicillin, very common. It is now the first line dose for antibiotics for oral infection. It can increase INR bleeding. Okay. Erythromycin, azithromycin, Z-Pak, again, it can increase bleeding. NSAIDs, no brainer. They actually will compete with the warfarin on the abdomen, knocking off more warfarin, increasing their INR again. Flagyl, again, increases INR. Personally, when I have a patient who has warfarin, I give them clindamycin, and that does not increase the INR. Okay, so these are things you might see or do in your daily practice. These are some things which you probably should know about. Okay. So what should we do? The answer is low risk. If you look at the surgeries, of heart surgery, foot surgery, we are considered low risk surgery. Okay, we are very, very fortunate to have a post-op bleed after a surgical extraction below 1%, and about 7% with patients who are anticoagulated with INR less than 4. It is not commonly recommended to stop. For an INR less than 4 only on warfarin, or an INR less than 3.5 with an antiplatelet therapy. So really, my patients, I always kind of ask for the INR within 24 hours. And it's usually not a problem. In fact, now you can buy your own INR machine for your office for about $600. You can get on Amazon. Hand to God, Amazon sells these things right now. And unfortunately, you will not get reimbursed if you're not a lab. But if you really are that diligent, you can buy one of these units and know exactly what the INR, and they're pretty accurate.
So you're saying they should have, I was writing.
Oh, sorry, here, please.
But you were saying that, when are you saying that they should have an INR for sure? If they're on any of those anticoagulants?
No, INR is only for warfarin.
Right.
Yes. So if they're on warfarin, I usually ask for an INR within 24 hours, just because you never know. And the problem with warfarin, I wanted to save the punchline for the next drug, is that warfarin, diet can play a big effect in these things. All right. And that's why whenever you see, Xarelto being advertised, or all eating green spinach salads, there's a reason for that. Because there's a lot of foods that can knock off warfarin and increase your INR. So, you just never know. And the thing is that really it's a CYA thing. I want to be sure that I'm doing the best possible treatment to my patients, and really I have no excuse not to. And because I know better. Yes.
Well, patients that are seeing moms, with an iron arm, you have a therapeutic range. With the Plavix and Xarelto, there is no therapeutic range.
Nope.
So, and if you ask the patient, what are they taking it for, they'll give you some nebulous reason. Well, I say, what, you tell your doctor to call me, and what we do is that you tell them what we're gonna do and have them, they have to fax us over.
And they list.
Yeah, a list, and if we, because Plavix used to be, you had to discontinue it 5 to 7 days ahead of time. But it
Exactly.
seems to be changing.
Exactly.
It seems to be changing, so I said, no, you send me that in writing, so that we can put it in the patient.
Another trick, which is great, call their doctor. Another trick, which I use all the time, because I see a lot of patients who are a little more elderly, they may have dementia, they may not know all their drugs. A lot of them are on a scroll full of drugs, right? How do you keep it all? I can barely keep my like lunch that I had yesterday intact. One thing to do is actually call the pharmacy. Sometimes even faster. Say, what pharmacy do you go to? I'll call them, and they'd be happy to fax over their drug list. If you go call a doctor's office, can you get to the nurse? Can you get to the doctor? That takes time. Calling the pharmacy is a great little trick. I do it all the time. And thing is, you should never treat a stranger. Because not knowing their medication is not an excuse. You're a doctor. You have those letters after your name. You have the big bucks. They're gonna come after you. So I always said, I want to know who I'm treating, and if they don't know their medications, I just call and I find out. Because you're right. If you know their drug list, you probably know what they're being treated for, right? So let's go on to the fun stuff, okay? So this is a new class of anticoagulants. I'm sure we've all seen the ads. It is amazing what drug companies are doing today. They are no longer advertising to you guys. Obviously, they can't get the sunshine laws, but they're now going right after our patients. Now, our patients are asking their doctors, what about this drug? It's good enough for the late Arnold Palmer or Chris Bosh. I'm not in NASCAR. Do anyone know who this guy is? I keep on forgetting. Anyway, so you always see these guys on TV. They're all having fun together. Life is great. There's a new class of drugs called direct oral anticoagulants. Okay, they're released in 2009. And what's driving the sales of these drugs is that they have a much safer profile. One is that there's less drug and dye interactions. Remember, they're eating those green salads, in the ads, always at the end. There's no routine lab monitoring, right? There's no tests that are needed to monitor the level of anticoagulation. And in fact, the tests that we have in PT and PTT, they could be used, but they don't actually tell you how effective these drugs are. You actually have to kind of look at enzymatic assays, which are not available in hospitals, usually up in labs. It's just for research. Now, that might change later. Right now, there's no routine lab monitoring. The greatest thing is that they're fast on, fast off. They're short acting. They're quick. So if you do have a bleed really or anything, you stop it for a while, and as long as they're not changing hypertensive events or anything, usually it's fine. And they have a wide therapeutic window, and there's a fixed daily dose. Warfarin, they can take 2.5 milligrams in the morning, 5 at night. It all depends on their INR values. So it's just a simpler drug to prescribe with less monitoring. It's cheaper for the for the patient and for the drug company or for their insurance companies. It's a great drug. Don't get me wrong. The problem is that we really just don't. We're just learning about them now. Okay. So there's two groups essentially. Okay. They're your Zabans. All right. Which includes, Eliquis, Xarelto, and the edoxaban. I haven't seen much of it, to be quite honest. But it's also out there as well. But the two most that I see is Xarelto and the Eliquis. And those are two I always see on the TV. And then there's second ones called Pradaxa, which is basically acting on the thrombin, directly. That's also out there as well. They're usually taken twice a day, except for the edoxaban, that's usually once a day. Now, there are only 3 current therapeutic uses right now. I guarantee you that will change as they find these more. Obviously, as the studies come out and the companies have the money to put it, towards it, these studies, this is going to change. The first one is to prevent stroke in non-valvular atrial fibrillation. The second one is to prevent deep vein thrombosis and also pulmonary embolism. And the third one is for prophylaxis use after orthopedic surgery. So right now there's only 3 uses. But once again, AFib and PE and deep vein thrombosis you might see in your office. Now let's get back to the chart over here again. See warfarin, a ton of effects.
we're working on a lot of different levels. The Xavans work on the common pathway, factor 10. This one over here, Devigatran, that works right on the thrombin. So these are direct inhibitors, and they don't have a lot of side effects. Therefore, a lot of these different enzymes don't need a lot of time to kind of rebuild to get you back to a normal coagulative state. But why are we so nervous about these drugs? Because we don't know them. They just were recently approved. There's no reversals for them. Warfarin, you can give them vitamin K, you can give them coagulation factors, they'll get back to normal. Platelets, Clopidogrel, give them active platelets, that's fine. But these drugs have no reversal, except for Pradaxa, which has a drug called Praxibon. This actually just came out, okay? And there's no tests that we know to actually give us a reliable measure of how well they are working, okay? Again, no high-powered studies on those, and there's no official recommendation made by many of the authoritarian academies out there, just still too fresh. This was the first article that I could find which really did a good job of looking at all of the literature, okay? The first review, again, you're looking at 2016, just last year, okay? And essentially, they found in this study that you basically just treat them as though they're on warfarin from 2.0 to 3.0, and that's kind of a safe way to manage these, as long as it's not high-risk surgery. They never define, what is really high risk, but there are a lot of papers that went back and forth. But this is the first article that first came out, basically saying that it was pretty safe to kind of do surgical extractions, while they're still on it. First prospective study I could find, okay, 2016 November, all right, is based out of France. And they basically found, well, I'll kind of go over with you, they had patients who were on vitamin K inhibitors, okay, or direct oral anticoagulants. They did a total of 126 extractions. 73 were in the direct oral anticoagulants, and 53 were in the vitamin K antagonists. And the INR value for those on the vitamin K was 2 to 3. Okay, so once again, therapeutic range for most ailments. And obviously the patient pool, it's kind of mean age of 70.26 plus or minus 2.07, so kind of all in the same range. Most patients were on Xarelto. Now, why I mentioned it was from France because warfarin's most common in the U.S. While there's a drug called I believe it's fluocinolone. That's the most commonly prescribed anti-K drug in France, okay? But it works on the same system. All right, over here again, what do they find? That most bleeds, if you're on direct oral anticoagulants, kind of stopped in the, between 20 minutes and 3 hours, okay? That's where most of them stopped. There are 2 patients in direct oral anticoagulants that had a late bleed. That's 2. And late bleed being between 40 hours and 72 hours. Kind of, they had a rebleed. Notice there's a gap over here between 24 and 48. So they had a rebleed, okay? But what is most important? Remember, hospitalizations, goose eggs, 0. Local measures is all you need to help stop bleeding. So once again, although this is a newer drug and we're still learning about it, and obviously as the more studies come out, we'll know more and more and more. I'm sure that there'll be the outlier here and there, kind of like my first video where I kind of caused a big issue. That's fun. So again, no one needed more than just local measures in your office. Goose eggs. Conclusion. DNOCs can be continued in patients undergoing tooth extractions, and that the application of local chemotherapy measures is enough to stop a postoperative bleed. Now, that being said, there's no official recommendations from any academies just yet. The packaging in these drugs say stop at 24 hours before, okay, and don't start it back until the bleeding is secured, all right? That is the official recommendation from the manufacturers. The ADA, this is kind of their statement right now, okay? Basically saying that really the serious risk of stopping these drugs need to be balanced against the potential consequences. Again, no official statement, just it's really up to you and your clinical judgment right now. Here's kind of the ADA's statement on all these drugs, okay? Essentially saying that really you don't need to stop any of these drugs right now. Obviously use clinical judgment.
These drugs versus aspirin, the cardiologist would let you stop them for 2 days.
Sorry?
Instead of 7. You can stop these medications, the
Which ones?
Xarelto and the Pradaxa,
So
2 days before the
So-
procedure versus aspirin 7 days.
yeah, so they're fast on, fast off. So you usually say 24 hours. You're absolutely right on that. Because once again, they're fast on, fast off. So once again, what is high, what is low risk? This came from the Scottish Dental Effectiveness Program. Again, this actually looked at more than just dental extraction, looked at general, just dentistry in general. Obviously, any dental prophies unlikely to cause a bleed, periodontal exam unlikely to cause a bleed, orthodontic stuff, also unlikely to cause a bleed. Really, a high risk is large wounds, okay, so multiple teeth which are coinciding next to each other. Biopsy, remember the one that from the clinicals of North America said anything greater than 3 is high risk, and obviously gingival recontouring. So again, all these tables that you find, it all depends on the clinician's judgment as well as what clinic they work with. There's no official recognition of what's high and what's low. Local measures. So what can we do in our office to prevent a bleed? Well, there's a bunch of items on the market. I'm sure you all seen Clog Tape. Basically just collagen either in a little bullet form or in a piece of tape. It's self-resorbing and it actually will retain its integrity when wet. What all it does is act as a scaffolding. It's relatively inexpensive. And what I like about this, it actually, because it retains its integrity, you can shove it in the socket nice and hard, really compact it there. It'll actually act as a mechanical block for the bleed.
Oh, so that doesn't get all gummy-like.
Like, exactly. I love you, man. Good job. Gel foam. It's cheap. Yes, sorry.
Do you have to suture that in? So
I do.
the-
So just the act of the suturing itself will also help stabilize it with the clot. So kind of keep some down pressure. Plus it'll act as a scaffolding. So yeah. So I would recommend throw a little suture in there because it pops out. 1, they swallow, they don't like it, and 2, it's a little extra protection. So yeah, I usually do. Gel foam, okay? Sterilized porcine skin gelatin, okay? Again, acts as a scaffolding for the platelets. It's poor for pressure hemostasis, exactly what you mentioned. It sucks.
But I have had good results with it if I get 2 or 3 pieces and smush them together real hard.
And when it turns this messy,
It does.
yeah, it's not fun. It's very cheap, but not as effective as a collagen-based product. And the problem with gel foam is you put too much in there, it causes these giant cell reactions. Ever had a patient come back and had that little granuloma in there, and it's still first, it's not feeling well. It's because of gel foam normally, okay? And all these drugs are only good for bleeding really if there's no thrombocytopenia or lack of platelets. Because all these do is act as a scaffolding. So if you have low platelets, well, guess what? It's not going to help very much, but I still would put it in there. Bone wax, okay? Actually, this has been around since 1886. I didn't know that. Since 1886, they've had bone wax available. It's beeswax mixed with paraffin and isopropyl palmitate, a softening agent, and all of this acts as a mechanical bleed. It's good for bone channels. It's great. The problem is that they don't reabsorb. It can cause mild inflammation, actually can cause nitis-4 infection, and these do tend to work their way out. So I've done some third molars where I've tried a little bleed, I pulled bone waxer, they'll come back 4 months later with a little pain, and you got to chip out the actual bone wax and it's gone. So these will come back to haunt you. But for a mechanical or a blood vessel channel bleed, these are what you want to use, or arterial pumping.
My experience with bone wax is I always just controlled the heme and then removed it. Can you cover over bone wax and then come back later?
Oh yeah, if it's an arterial bleed, okay, I mean it's really pumping. You take that bone wax out, like very likely if they increase their blood pressure or anything, you might just rebleed again because the vessel's actually inside the bone. You can't clamp down, and having the external stuff like the collagen won't put pressure on that vessel. So the best thing for vessels is pressure. So yeah, you can keep it in, but sometimes it'll come back to haunt you. Absolutely.
Okay, so if it doesn't rear its head later though,
I keep it in because
once again, first of all, we know from many other surgical specialties like orthopedics where they can't come back in, they leave it behind. But like I said, and once again, if you remember a rebleed, if they increase their blood pressure, again, that vessel will pop open, and then it said it's 3 in the afternoon, 3 in the morning, you gotta go to your office, it's a whole pain. Methicillus or Surgicel, this is the good stuff. It's more expensive, I'm not gonna lie to you guys. It's wonderful. This is what we use in the operating room. It's basically oxidized cellulose. It acts as a mesh network, but once again, allowing the platelets to kind of hang out for a little bit. It's a negative pH, it's bacteriostatic, it actually will prevent infections, right? And plus, it actually will hold or retain its shape. You can put pressure on that, it'll act as a mechanical block as well. So this is great stuff. And the thing is, notice the size, 4 inches by 8 inches, huge. These can come as like blankets. What we do is we actually cut them up in little pieces and put little baggies, because you only need a little piece. You don't need a big ton of it. So this stuff is pricey, but once again, it's worth every penny, and you cut up little pieces, put it away, and it's fine to use. This is the new stuff that you always hear about, the shrimp shells. This one actually was used in the military for femoral bleeding. And if everyone's seen a femoral bleed, hopefully never, those things are big deals. So if it can stop a femoral bleed, it'll stop a little bit of a tooth bleed, okay? So once again, initially it was for medics on the battlefield. And the way it works is actually it's positively charged. It'll actually cause RBCs, or red blood cells, to actually kind of coagulate together and create a little block, so you actually can get some coagulation going. When these first came out, not only were they expensive, but they did not resorb, so you had to go back and actually get these, so you only used it when you really, really had to. But actually, they now have dental dressings, which actually can, from HemeCon, you actually put it inside the socket, walk away, it'll break down on its own. So these are actually great. I actually looked into this. I think it's $110 for 10 pieces, and they're small little ones, but $110 for opening your office, it's great. Now this is the one that I love, which I think is not utilized as much as it should be. I use it for any kind of patients who have a coagulopathy, or like liver disease, or any kind of factor 8 or 9 issue. It is a mouth rinse which you can actually order from the pharmacy. The key is that it's not from Walgreens, not from CVS. I can tell you right now that you usually gotta find a compounding pharmacy. It's made fresh. I think it's a 15-day shelf life only. I know Neil's Pharmacy near us, they do a lot of it, and I think it's $100 if you have no insurance, but they give you a big bottle of it. And essentially, it is a tranexamic acid mouth rinse. It basically stabilizes, the clot. And the way you use it, you actually ask the patient to hold it in their mouth for about 2 minutes, then spit it out, and they can do it every 2 minutes. And what I also do—
2 minutes or every 2 hours?
Every 2 hours. I apologize. Now that being said, what I actually do is actually put it on the gauze when they're in the actual post-operative area. They bite down on that gauze, they put it directly over the wound, they go home and they rinse every 2 hours, or hold it and then rinse. It's a great drug. It works very well. We use a lot in the hospital. The only thing is that it's a little harder to find. You probably have to find a compounding pharmacy to actually get this made for you. Tea bag. We all heard that. I'm sure everyone has it on their post-operative sheet. Use a tea bag. All it is tannic acid. Okay, it can't be green tea. It can't be passion kumquat. It has to be just normal black tea. Okay, and what it does, it basically acts as a vasoconstrictor, giving time for things to kind of clot up. Nothing special. So, dental death, a review. Ooh, now it's getting serious. Okay. So this is a review article, came back again, 2016. This is recent stuff, guys, hot off the actual press. And how do we cause death? It's look at the numbers. All they go from 1960 to 2015. The biggest death is really coming mostly from anesthesia or sedation. Now that being said, that's dropped down significantly. I can tell you the drugs that we use now is much better than it was 15 years ago. I can tell you that Brevitol was a horrible drug. It caused a lot of laryngospasms. People were just always being bagged. Now with propofol, much nicer, much less risk of having all these airway issues. Infection, another one. It's kind of interesting. Actually, it's increasing. All right. So the theory behind that is that obviously we know all the new superbugs in the hospital, all the antibiotic resistance. Now this is making its comeback. But look at the bleeds. Been pretty consistent.
0 in the 60s. You know, 1 in the 70s, 1 in the 80s, 1 in the 90s, 1 in the 2000s, and now 1 in 2010. So remember, you have a liter and a half, folks, a liter and a half before you see some changes. You have plenty of time to treat this in your office. Don't freak out unless it's an arterial bleed. So let's have something which always kind of bugs a lot of my medical colleagues, medical clearance, all right? It's when a surgeon requests, a surgeon or doctor, we are doing surgery on patients, asks for clearance for assessing a physician before performing surgery on a patient. It does not clear you or the patient of risk. There's still risk there. You just want to know, what is my risk, okay? It's a medical misnomer because there's still risk. No patient is free of risk and helps us determine the actual risk. Same word. And again, the decision of whether to perform the surgery or not is still up to you and the patient, not the cardiologist. It's up to you guys, okay? So how do you avoid malpractice? The first thing is determine which patient needs medical clearance. Make sure you actually ask someone, is this patient risky or not for the procedure? Obviously, provide appropriate information to the doctor. What are you doing? What kind of anesthesia? How long is it? Is it going to be? What's the post-operative course like? And then develop a plan to mitigate those risks. Obviously, having local measures in your office and whatnot. So, you're never going to get clearance. You're going to get, what is my risk for this procedure? Okay, so you're still kind of on the line there. So this is the big article, came out in the American Journal of Medicine back in 2014. This is not look at direct oral anticoagulants, but did look at antiplatelet therapies. And what's amazing is that, with the statement of the American Dental Association, American College of Cardiology, and the Society for Angiography and Interventions, American College of Surgeons, they all say that, do not stop the anticoagulation. Notice the title, the title, bleed or die, okay? So you have a higher risk. In this article, they said there's a very remote chance, about 0.2%, of having a bleed that, that you can't handle versus having a fatal event. So really, guys, again, the theme of this is we now believe, it's better to bleed a little bit than have a problem down the road. So like anything else, every few years, you must unlearn what you've learned. You will know good from bad when you are calm.